Welcome guys. So here in this video section, we are going to discuss about the OSCE pattern recall of this January DNB General Medicine practical session. Now why OSCE is important? OSCE is important for you because it is around 100 marks and it's sure short marks. If you make it correct, you get 5 out of 5 in each of the question. There are 20 question along with timer and this 100 mark is completely in your hand, isn't it? Because how your viva will go, how your practical will go, there is no surety about it. There is lot of about impression, your speaking skill, everything goes in your viva and practical part. But in OSCE, it is completely your knowledge and how do you express your knowledge within the stipulated time in the exam paper, right? So coming to the discussion part, this series is based on the recall of the student, obviously, and as you know, as there is recall, there will be some sort of mistake in the questions too. So before going to the detail, I would just like to say that this is almost like 1 year. We are going for 1 year of our DNV medicine notes, which almost started as experimental app. It is available both in Play Store as well as iOS platform, and 3 courses are ongoing. Mainly our theory note, which is huge success with more than 2000 of active users. Then we have OSCE courses coming up. OSCE courses live, and the student who will be enrolling in this OSCE and practical courses will have live discussion, mock wide rounds to help them prepare them about the fear to present the case in front of examiner. We are going to start from the August onwards. Okay. Next, we have also the courses of cardio DRNB note. Now, previous time during the practical session, we have organized about the mock word rounds and case presentation. Similarly, with collaboration of other faculties, notable national faculties, we are also going to organize this time for you all. Okay. Beside this, I would also like to announce we are also expanding and we are expanding to other field, and within few months we are going to expand to pulmonology notes and OSCE as well as pediatrics notes and OSCE apps. All right. Now coming to the discussion part, let's see the first question. So what does this question says about? Okay, it is about a 72-year-old 72-year-old male who is brought with daughter with complaint of progressive memory loss. All right. And there is word finding difficulty, occasional disorientation to time for the past 1.5 year. So that is something of a chronic loss you can get from the question itself, and it is a progressive nature. All right. So what are the important thing you need to know? You need to know what are the causes of reversible memory loss. Mainly the vitamin deficiencies, electrolyte imbalance, or CNS infections like meningitis. All of those are causes of reversible loss. Even one of the important one is delirium, which causes pseudo dementia, is one of the differential of reversible memory loss, right? Now his MMS score is 20/30. That is the objective definition of defining how that memory is impaired. No focal neurological deficit. MRI is showing diffuse cortical atrophy with prominence in temporoparietal areas. So based on the history and MRI, what is the likely diagnosis? So clearly this is everything depicting here is about cognitive impairment, and this cognitive impairment can be moderate to severe, and at this age group, which is the most common cause that should come in your mind, most common cause that should come in your mind is nothing but the Alzheimer disease. All right. Okay. So coming to the next question, name to pharmacological treatment approved for mild to moderate Alzheimer. So two pharmacological agent that which we should know is about donepezil and memantine. You can also quote about the reverse Tegmin-2. This is also used, as well as Tecrin in some cases, but not used currently. So donepezil is usually given in 5 milligram doses, sometimes tapered to 20 even. So what is donepezil? Donepezil is nothing but cholinesterase inhibitor. Okay, and what is memantine? Memantine is NDM receptor antagonist. So memantine is NMDA receptor antagonist, and this memantine is used in mild to moderate disease. Okay, all right. So Beside this pharmacological approach, next thing you should also know which question can be asked regarding this question or regarding related to Alzheimer is that non-pharmacological intervention. So, non-pharmacological intervention helpful in Alzheimer can be cognitive behavioral therapy, CBT, cognitive behavioral therapy in the form of stimulation or caregiver support. All right. Okay. So, what are the other differential diagnosis? The differential diagnosis at this age group, which I should keep in mind, is obviously vascular dementia, or I would obviously like to keep the differential of frontotemporal dementia. But what are the point that goes against them? Vascular dementia will have stepladder pattern of dementia, might have history of hypertension, might have history of stroke or vascular event in past, and frontotemporal dementia will have frontal lobe syndrome in the form of psychiatric symptoms. Okay, so which was absent in this case. Now, other thing that I would like to point out here is that as you can see, MRI finding has been mentioned to be prominence in temporoparietal areas. So, in neuroimaging of Alzheimer's disease, there can be bilateral temporoparietal increase atrophy, all right, which is can be seen in MRI and especially in the hippocampus areas or medial temporal lobe areas. So, similarly, there is prominence in the temporoparietal areas. Okay. Now, moving to the next question. So, here as you can see, a 35-year-old lady is coming. So, with complaints of tightness of the skin over the face and the finger, right? And then there is difficulty swallowing. Okay, so esophageal problem is there along with the tightness and episode of finger turning white and painful on cold exposure. So, what is this important clue? This important clue is nothing but about the Raynaud's phenomena, right? Raynaud's phenomenon. Now, examination is revealing sclerodactyly, that is tightening of the skin again, and digital ulcer. ANA is positive with nucleolar pattern. So, likely diagnosis. So, likely diagnosis, what are we dealing with? We are dealing obviously with systemic sclerosis which involves the or scleroderma per se, which involves the skin. So, you know, systemic sclerosis of two type. Either is limited or diffuse. Diffuse have more of organ involvement pattern, diffuse cutaneous systemic sclerosis, whereas limited variety involves mainly the skin part. Okay, so it involves the face and the distal limb is seen in limited variety, whereas in diffuse part there is proximal skin involvement, but other visceral organ involvement can be seen, and visceral involvement will be early in the course of the disease in diffuse, whereas it will be very late in case of limited cutaneous systemic sclerosis. So, what are the features that will support my diagnosis? For example, you can see here there is skin tightening. So, number one point, I will write tightening of the skin has been shown around the face and the digits. There is difficulty in swelling. What does difficulty in swelling clinically we say? We clinically say it to be dysphagia. And dysphagia, what does it represent? It represents esophageal dysmotility. Okay. Then there is Raynaud phenomena in this patient, third point. Okay. Then digital ulceration is present and positive ANA with nuclear pattern. All of this will suggest towards my diagnosis. Now, there is something known as CRASH syndrome that you should also know in this case. So, what is CRASH syndrome? CRASH itself the mnemonic, right? So, C for calcinosis cutis due to deposition of calcium crystals, R for Raynaud's phenomena, E for esophageal dysmotility, S for sclerodactyly, T for telangiectasia. Among these, all of those points, Raynaud's phenomena is present in this patient, esophageal dysmotility is present in the patient, and sclerodactyly is present in the patient. So, most likely this is a limited variety. Okay. So, what are the two major types? I have already discussed about limited variety and diffuse variety. Two serious complication. Okay, this you need to know. So, what are the cause of death in case of this? In case of this can be either due to pulmonary complication or renal complication. Pulmonary complication in the form of pulmonary artery hypertension related to hypoxia and death, or renal complication in the form of scleroderma, renal crisis. All right. Then specific antibody, if I speak about for limited variety, this is Krebs syndrome is present and antibody is known as anti-centromere antibody. Anti-centromere antibody. Whereas for the diffuse variety, the antibody is anti-SCL70 or anti-topoisomerase 2. Anti-SCL70 or topoisomerase. Okay. So these are the antibodies associated with scleroderma or systemic sclerosis. All right. Okay. So if you see this table from Harrison, which is very important for exam. So you can see the skin involvement in case of limited skin thickening starts slowly, initially from the fingers, hand, face and areas below our elbows. Then it gradually progresses upward. Whereas in case of diffuse variety, skin tightening or thickening will happen very quick like wildfire, and it will spread widely affecting the fingers, arms, legs, face and even the torso, right? So in diffuse it is very quick diffusion of the skin involvement, in whereas in the limited it will start slowly. Okay, so as you can see here, indolent onset, that is slow onset it means, and diffuse it is rapid onset, and there is limited to finger, distal to elbows, face slow progression, and there is rapid progression in case of diffuse variety. Now Raynaud's phenomena, that is finger or toes turning white or blue in cold or stress, in case of limited appears years before the skin symptom develop. So it can cause severe finger or toe circulation issues, and sometimes this due to the circulation problem there can be gangrenous changes too in later period, right? Whereas in diffuse variety, Raynaud's phenomena starts around the same time as skin symptom. Therefore, severe circulation problem is rare in diffuse and or more common in limited variety. So Raynaud's in case of limited, it starts by years or involvement by year may be associated with critical ischemia in the digit. So it antedates skin involvement, means because it starts before the skin symptom involvement, whereas in diffuse variety it starts hand in hand together. Okay. Now, MSK symptom, that is musculoskeletal symptom, or better to say bone, joint or muscle pain, it will be milder in limited, whereas severe joint pain, diffuse pain can be seen in case of musculoskeletal syndrome involvement in diffuse variety, and sometimes there can be association of carpal tunnel syndrome or tendon friction rupts. Okay. Now, ILD being an organ system manifestation, obviously it will be more common in diffuse variety. And regarding pulmonary arterial hypertension, will happen alongside lung scarring in diffuse variety, but in case of limited it appears late, or it occurs in association with ILD in case of pulmonary arterial hypertension. Now, renal crisis is very rare in limited and occurs in around 15% population in case of diffuse variety. Calcinosis cutis being a skin change is more common, and also being a part of the crest syndrome is more common in limited compared to the diffuse variety. Antibody is anti-centromere, anti-topoisomerase 1 or anti-SCL70 or anti-RNA polymerase 3. These are the antibodies which can be seen. All right. Okay. So this is the image about the Raynaud's phenomena, and this Raynaud's phenomena independent question can be asked on the similar pattern from this Raynaud's phenomena too. All right. Okay. Now moving to the next question from the repeat section. So clearly, even if I don't read the question, if you can see red inflamed swollen joint about the first metatarsophalangeal joint, and it is nothing but it is a gout and acute gout, right? So just read the question again. So here a 60-year-old man with stage 4 CKD, right? So with stage 4 CKD is presenting with acute pain and swelling of the right grade 2, as you can see here, and he has a history of hypertension and is on diuretic mainly furosemide, which is a loop diuretic. Uric acid level is in the higher range 9.8, and joint aspiration has already been done, which shows needle shaped negatively bifurcated crystal. So what does it mean? It also gives the diagnosis of acute gouty arthritis. Now You know this is the acute gouty arthritis. This is a very good answer for MCQ question. But for the OSCE pattern, you need to as much as correct as much as you are possible, because there are step marking, right? So what is the likely diagnosis? You will write likely diagnosis to be acute gouty arthritis of right first MTP joint. This is the number one diagnosis. Number two diagnosis, you should write stage 4 CKD. You should never miss the two conditions here mentioned. Here is, it has been already mentioned about the stage 4 CKD. You should also mention that. Only then you will get full marks in it. Okay. So what clinical features suggest or supports your diagnosis? Again, it is very easy. Fast MTP joint involvement, high uric acid history, CKD. Why does CKD history is important? Because there is reduction of urate clearance in case of CKD. Then crystal proven diagnosis, like there is incredibly bifurcation, leadership, crystal in synovial fluid. All of this will point to acute gouty arthritis. So what are the risk factor? If I say risk factor is obviously CKD in this case, and another risk factor being use of loop diuretics. Why? Because loop diuretics like furosemide increases the uric acid retention part. Okay. So safe drug. So safe drug, because why we are asking this? We are asking this because this is a CKD case and all NSAIDs cannot be given easily because of the CKD profile of the patient. In such cases, choice would be prednisolone, oral prednisolone. Injectable is not required in most of the cases, or along with you can give colchicine. Colchicine is not as per contraindicated, but you should obviously check for creatinine clearance. So colchicine under guidance of creatinine clearance monitoring, as well as some cases injectable steroid intraarticular, right? Intraarticular injection can be preferred. So what are the non-pharmacological strategy? Non-pharmacological strategy, in this case, what I will advise to go for, obviously there is no proven data, but still for exam you can write. For advice you can also give to the patient low purine based diet, then to control of CKD, third to avoid triggers like alcohol which are known trigger, and obviously weight is not mentioned, but in such cases weight reduction do helps. Okay, so that's all regarding the this OSCE question. Okay, all right. Now coming to the next question, a 21-year-old male of tribal origin presents with recurrent episodes of joint pain. All right. So, and there is fatigue associated with the joint pain. He reports a history of dactylitis in childhood. So, you can see there is dactylitis, very important clue. On examination, scleral icterus, pallor. So, there is icterus and pallor. Both of these goes towards hemolytic anemia. Again, there is mild splenomegaly which suggests hemolytic anemia ongoing, hemoglobin of low, peripheral smear is shown below, hemoglobin electrophoresis report is given. Okay, so what you can get from here, the diagnosis, as you can see the peripheral smear, very clearly you can see there are a lot of sickle shift cell. So what is the most likely diagnosis? Most likely diagnosis is sickle cell anemia. All right. Now clinical features supporting the diagnosis. So as you can see, there is history of recurrent joint pain, right? Now before going to the recurrent joint pain or clinical feature, if I say what are the other important point mentioned, the history itself suggests, it suggests the tribal origin. Why so? Tribal origin, because there is high prevalence of sickle cell gene in Indian tribal population, mainly in the central Indian, Orissa, Chhattisgarh or Maharashtra belt. There is high prevalence of sickle cell gene. Therefore, this sickle cell anemia is very much common in these regions. So classic clinical picture, if I say, which has been mentioned, the question is about recurrent joint pain. So why there is recurrent joint pain? Due to the vaso-occlusive crisis. Why there is vaso-occlusive crisis? Because these sickled RBCs, block the microcirculation, right? Block the microcirculation, resulting into ischemia and severe pain, and which is commonly seen in the joints. Okay. Now there is jaundice also mentioned. Why there is jaundice? Jaundice is because of hemolysis. So recurrent episode of joint pain because of the crisis, sickle cell crisis. All right. Then there is history of pallor. Why there is pallor? Because of hemolysis again. There is dactylitis. So dactylitis is one of the earliest signs of vaso-occlusive crisis which is seen in infants, and there will be painful swelling of the hands or foot. Okay. There is splenomegaly also mentioned. So splenomegaly can happen sometimes in older population too, but splenomegaly in young age doesn't make sense, right? Obviously there is ongoing pathology inside. So early in the disease there is splenomegaly, and this is due to the decongestion of the spleen by this sickled RBCs. Once this sickled RBCs increases and splenomegaly enlarges very high, then there is chances of autosplenectomy in such cases too. Okay. So what clinical features support this diagnosis? Obviously, these four we are going to talk about: joint pain, jaundice, pallor, splenomegaly, as well as dactylitis. All of those supports the diagnosis of sickle cell anemia. So name to acute complication. So this is very important, right? So acute complication and chronic complication. This is often the pet question for the exams. So remember, there is vaso-occlusive crisis, vessels get blocked. So if the vessel of important vital organs can block, it can lead to acute complication, life-threatening complication. What are the life-threatening complication we need to discuss about? We need to discuss about acute chest syndromes or cardiac syndrome, ACS, acute coronary syndrome rather, and there can be stroke in the form of ischemic stroke can happen, obviously. Okay. So other thing that can occur, is aplastic crisis, or there can be chances of priapism too. All right. So these are the acute complication. Regarding the chronic complication, we need to discuss about avascular necrosis of long bones because of the vaso-occlusive crisis only, and because of there is chronic hemolysis ongoing, there can be chances of gallstone formation. Gallstone will lead to pancreatitis like effect. Because of the dactylitis, there can be ulceration formation, ulceration in the form of digits, in that leading to digital gangrene. Sometimes there can be renal papillary necrosis too. Okay. So how do you manage the case? The cornerstone for management in the treatment part is nothing but hydroxyurea. So what does hydroxyurea do? It increases the HbF level, right? So it increases the HbF, therefore there is less stress on the hemoglobin to carry oxygen and less vaso-occlusive event occurs. Also beside this, as there is chance of autosplenectomy, therefore to prevent infection for the capsulated organism, in such cases vaccination and prophylaxis of penicillin is advised. Okay. Okay. So other thing that in, in emergent condition or acute condition, exchange transfusion can be done. Exchange transfusion for stroke prevention or stroke like symptom, or there is severe vaso-occlusive crisis which may lead to death like scenario in such cases, or even the patient of sickle cell anemia is thought that might get into stress in future. For example, there is ongoing pregnancy or there is surgery, major surgery is evident. In such cases, exchange transfusion can be sought. Okay. All right. Now let's move into the next question. So this is the last question of this set that I am discussing now. So 12-year-old boy is brought to the OPD with complaint of blue discoloration of lips and fingers. So what is it? It is nothing but cyanosis. Case of a cyanosis. And during exertion, cyanosis increases, and squatting during play from childhood, there is exertion of it. So the boy was noted to have systolic murmur on routine examination. Therefore, you already know this cyanosis is of cardiac origin. Okay. So, SpO2 is also less, it is 85%, there is hypoxic. So, chest X-ray is given, there is no chest symptom as such mentioned. So, this saturation, desaturation is also due to the cardiac origin of cyanosis. So, as you can see here in chest X-ray, if you identify, it is very good for exam, because this is been asked last year even, and this can be repeated too. So, you can see this is nothing but a boat shaped heart, and along with the history of cyanosis and hypoxia and systolic murmur, all of those goes towards what we call to be tetralogy of Fallot. Even the question stem itself gives us the help. Second question is, what are the four component of the case? So, four component, obviously we are dealing with tetralogy of Fallot. So, what are the four components? Four components, number one, there is VHD. In fact, the VHD gives the pansystolic murmur. So, beside this, there will be stenosis of the right pulmonary duct. So, right ventricular outflow tract obstruction. Then, because of the right ventricular outflow tract contraction, pressure in the right ventricle cavity will increase, resulting into right ventricular hypertrophy. And as the blood cannot flow to the right ventricular outflow tract, it needs to override the aorta. Override the aorta through the VHD. So, overriding of aorta. So, these are the four component of the tetralogy of Fallot. Now, why there is squatting after exertion? So, it because it relieves it. How it relieves? Because squatting increases the systemic vascular resistance. It is very understandable, right? If a person squats, if a boy squats, resistance, because of the increase in the pressure in the lower limb, there is increase in the systemic vascular resistance. As resistance is getting increased, right to left shunting across VHD will reduce, and therefore pulmonary blood flow and oxygenation will improve. That's why often these boys, often these kids go into the knee chest position. Similarly, if the boy cries, baby cries, suddenly they become blue in color, because there is cyanotic spell, because there is sudden worsening of cyanosis because of the increase in the right to left shunt. Okay. So, squatting. So, what does squatting helps in? It increases the systemic vascular resistance. All right. So, therefore, it will reduce the right to left shunt across VHD channel because of the increase in resistance. So, blood will flow across the normal channel, resulting into improving pulmonary blood flow and oxygenation. All right. So, what is the finding? Characteristic finding in chest X-ray is of the boat-shaped heart. And what is the ECG finding? This is very important question and interesting question too. Often most of the student what I have had is missed answering, but don't worry to miss it. Even if you don't know, just mention what are the things that is suspected from the changes you know. So, BHD, does it make change? Not actually. But does RVOT and RVH make changes? Yes. There will be feature of RVH in the form of a right axis deviation in case of ECG. Okay. And there also feature of RBH sometimes can be seen. All right. And overwriting of aorta also doesn't cause any symptom. So, what are the other management you should know? One is knee chest positioning of the baby, another is give oxygen because there is decrease in oxygen supply, and there is SpO2 reduced to give something that will reduce the stress. For example, giving morphine will help. Similarly, giving beta blocker will relieve the stress of the heart myocardium. Fluid management sometimes help, and soda bicarb can be given if the patient is acidotic. So, these are all the management skills that we need to know while managing the case of a tetralogy of Fallot, right? So, that's all about the 5 questions that I have discussed now, which is about the repeat questions. In next session, we will discuss more other questions about the repeat questions, repeat section mainly, and we are also announcing now about our live classes section for the targeting the DNB students, medicine candidates who will be appearing in the practical session. We will have mock word rounds as well as long case. Those who want to participate in it, obviously go through the course section, go into the app, text me in the group in the app about your case, and we will arrange faculty for you for participation.